Our next speaker is Laura Olah, Citizens for Safe Water Around Badger. Laura currently serves as executive director of that organization, and she's also statewide coordinator for the PFAS Community Campaign in Wisconsin and the national coordinator for the Ceasefire Campaign. For more than 30 years, her work has reflected her commitment to involving and empowering residents and tribal members in decisions that affect the environmental health of rural communities. She lives near the former Badger Army ammunition plant, which is the source of 4 groundwater contamination plumes. I'm pleased to bring Laura to our panel.
Hi, thank you. My talk today is about medical monitoring and access to presumptive care. I live near an old Army ammunition plant, as you mentioned, here in Wisconsin. And a few months ago, the Army held a public meeting to discuss the groundwater contamination that has migrated off-site and is discharging to the Wisconsin River. We asked about recommendations from hydrogeologists with the U.S. Geological Survey. They advised the Army to test drinking water wells on the other side of the river, something that hasn't happened in the last 30 years of study. And at this meeting, the Army guy argued against the recommended testing, saying that even if they tested the well, there would be no way of proving that the contamination came from the base. And anyway, they don't know which drinking water wells to test. So their logic was, because we as community members cannot prove any detected contaminants are from the Army, and because they don't know which ones to test. I lost my place here. Then they weren't going to test anyone. It's like we weren't sure who to test and if it's from us. Of course, this is ridiculous. If we don't know exactly which wells are at risk, then we need to test everyone's well. So the question becomes, so how does apply this to PFAS? And it's a similar question. Should we test everyone's blood for PFAS? If not everyone, who do we test? It's a key question. So let's begin with what we do know. We know that by limiting exposure to PFAS, we decrease health risk. And to limit exposure, we need to have a comprehensive understanding of contributing sources. And this is where communities and physicians are hitting a wall every time. Where is the PFAS data? And more importantly, who is being exposed? Here in Wisconsin, at military bases like Volk Field National Guard Base, concentrations of PFAS in groundwater have been detected as high as 23,000 parts per trillion. We asked the military to see the corresponding results for drinking water wells, and they required us to submit a federal open records request. This request has been deferred so many times, it has now been pending 3 years. So today, the test results are still withheld from the public, from service members and base workers, and even state regulators. So without access to the information, we don't know who is at greatest risk and who do we test. More than a year ago at another military base, this time in Tennessee, the Army at the Holston Army Ammunition Plant held a public meeting. Military announced that their initial site assessment for PFAS was complete and that, quote, nothing of concern was found in groundwater. So we asked for a copy of the written report so we could see the actual data, which is now 2 years old. Our request is being handled by Justine Barati, who is the Director of Public and Congressional Affairs with the Joint Munitions Command, who wrote, "The report is in the internal Army review and revision process. Therefore, it is not currently a finalized document. The document will be made available to the public once it is finalized and determined to be releasable." More recently, she advised me after 2 years to check again in 6 months. So who do we test and who's at greatest risk? These are examples of military point sources that are specific to drinking water, and I also want to talk about other routes of exposure. Let's begin with inhalation. Today, right now, with EPA's permission, the U.S. military is burning PFAS in the open air. It's in an open metal pan on the ground with added fuel and ignited. These are permitted, routine, uncontrolled releases of PFAS to the community. At the Holston Army Ammunition Plant, The military is permitted to annually open burn 1,250,000 pounds of hazardous munitions waste that may contain as much as 15% PFAS by weight. This is by weight. This is not, it's crazy. As we all know, PFAS are not destroyed in an open fire and therefore directly dispersed to the surrounding environment where they accumulate in people and dairy cattle and food crops and fisheries and wild game and in our unborn children. Nonetheless, just a few months ago, the state of Tennessee and the US EPA reissued a 10-year permit allowing this practice to continue, and the burning has been going on for decades. Unfortunately, this institutional secrecy is not limited to the military, as Andy mentioned before in her talk. At civilian sites nationwide, PFAS data is equally inaccessible. It is hidden behind proprietary privilege. Material safety data sheets for aqueous film-forming foam, which is also known as AFFF, identify PFAS as a, quote, proprietary mixture of proprietary fluorosurfactants. Again, there is no data to accurately characterize the source, which makes it impossible to correctly assess and prevent exposure and reduce risk to public health. The same holds true for PFAS in drinking water. In Wisconsin, there's less than 1% of all public drinking water supplies that have been tested for PFAS. For private residential wells, the percentage is even smaller. Therefore, we cannot know the degree of exposure and corresponding risk. My point is this: given all these barriers, the public and the medical community cannot identify which patients are at greatest risk to and harm from PFAS. Therefore, our care must be presumptive. And while we cannot predict the potential implications and future benefits of medical testing today, we know what will happen without this data. And we know this because we only need to look to the service members from the Vietnam War who are still fighting for presumptive care for a myriad of conditions linked to exposure to toxicants and Agent Orange in the 1970s. And again, for every deployment that has followed, to the service members today who are literally dying from exposure to toxic burn pits laced with PFAS. So I promise you, without medical monitoring data now, presumptive care will be out of reach for both civilians and service member and children exposed to PFAS now and 50 years from now. So just as I began at the beginning, that we must test all the wells on the other side of the river when we do not know who is at greatest risk, we must test everyone who wants to be tested. Through medical monitoring now, we will assure access to presumptive care and to better health outcomes now and in the future. Thank you.